The slide is being shown by Rajesh Sumaran, and you follow me as the line goes. I will describe whatever I am drawing. So to start with, I will draw the important dimensions of the orbit. It's a pyramidal shaped thing. The base of the pyramid is what is opening outside. So it has got a depth which goes till the apex, which is about 45 millimeters. And now that is the apex, 45 millimeters from the base to the apex. That is from the frontal plane to the apex. And horizontally, it is about 40 millimeters, and vertically, it is 35 millimeters. That's what I am drawing now. And you have got the relationship there. The superiorly, it is the frontal sinus, and inferiorly, it is the maxillary sinus. So with this itself, we can describe various lesions coming in, encroaching, and the cause of proptosis when the bony orbit itself is small by development due to premature synostosis. There will be proptosis. Now I am drawing a simple circle to start with, and then modifying it. See, then I'm modifying it. I'm drawing the tubercle of it. Now, then you mark the 9, 3, 12, 6 o'clock position so that you'll have you can draw these fissures and the foramina in the proper proportion and perspective inside the orbit. So that is the orbital foramen, and now I'm drawing the lesser wing, the superior ramus, body, inferior ramus. The palatine bone has been drawn as a small triangular piece of bone. Now I am drawing the ethmoid and marking the posterior and anterior ethmoidal foramen. So the way I am drawing it on the blackboard is that to display to you that you can draw it the same in a similar way on your answer book. So there goes the various bony sutures. Now the infraorbital fissure is converted into a canal, and the infraorbital foramen is there. I am drawing it just outside. Raju is the overlapping of the pictures. I don't know why it is not very smooth. Now I have drawn the pulley there in the upper part, the trochlea, and now I am drawing these the tendon of Zinn starting from the tubercle of Zinn, and now I am marking all the muscles which arise from the tendon of Zinn. Tendon of Zinn, the lateral rectus, superior, medial, inferior, and now I am drawing the superior oblique, which is going through the pulley, and it will be reflecting back into the globe. What do you see near the zygomatic bone or temporal to the orbital foramen and the fissure is the greater sphenoidal wing. You've got the lesser wing, medial to the fissure, greater wing, lateral to the fissure. Now I am marking the bones, that is the ethmoid. You see I am marking the origin of the inferior oblique there, just inside the tubercle there, inferiorly. Now I am drawing the interosseous membrane across the supraorbital fissure, and a small part is free for all the nerves and veins to come out. That is the lacrimal, facial, and trochlear. And then you have got the space there for superior ophthalmic vein, which is a constant vein. And at the tip of the supraorbital fissure, I have drawn a small circle that is a communicating artery between the lacrimal artery and the middle meningeal. And now I have just drawn the inside the circle of Zinn. I have drawn the abducen nerve, the two branches of the oculomotor, and then the nasociliary I have drawn there. Now I am detailing the optic foramen. I have drawn the optic nerve as such, and then there's a small indentation there to allow the central retinal artery to come out, ophthalmic artery and central artery to come out. I'm marking the lacrimal fossa there. To save time, I am also growing at breakneck speed. That is the middle palpebral ligament I am drawing, and then I have drawn the outline of the lacrimal sac. Now I am drawing the zygomatic nerve, which goes to zygomatic temporal and zygomatic facial. It comes out, and it also gives the parasympathetic branch supplied to the lacrimal gland. The anterior lacrimal crest, now I am marking. The That is the posterior lacrimal crest. Now I am marking the posterior lacrimal, which lies on the lacrimal bone. Now I am marking the lateral orbital tubercular bitnal, from which arises so many structures. The LPS, the lateral palpebral ligament. Now that I am marking the tubercular zin, which I already told you. So although it is a difficult diagram to draw, you can learn it by rehearsing and drawing it. And this drawing by me is just giving you a guide how to do it. See, this is a very composite diagram. You can display all the walls of the orbit through this one diagram: the roof, floor, middle, the apex, the medial wall, the lateral wall. Everything can be drawn. It can be displayed in one diagram. So if you are asked a question on any of these structures, you simply draw this one diagram and label the parts well. That is all. If you can draw a good diagram and label it properly, there is no need for any textual description. So that saves a lot of time. I'm marking the body of the sphenoid there, the superior ramus, inferior ramus, the lesser wing a little above. And temporal to the fissure is the greater wing sphenoid. So I'm almost nearing the end of the drawing. I'm growing very fast. I don't know, the video is running very fast. It's almost finished there. You can see all the parts they marked there. And there'll be one last diagram to complete. That is the frontozygomatic suture that will complete the diagram now. So that is it. So I'm sure you'd have followed it. This is difficult, but not that difficult, not impossible. Just learn it well. This will be a very easy thing to do at the examination. This will hold you good. Now, all the walls are there, the apex is there, and then some more details are there I have drawn in that. And also look at the Stellart's eye surgery. There also you see a diagram there with all the muscles displayed and the nerves going through it. So you can combine both and learn to draw a good orbital diagram. Now I'm going into the anatomy of the extraocular muscles. You look at the first picture that is shown to you now. See the now can I go to the previous slide? Yeah, that one. Now that one you can see the ciliary ganglion. This is a good composite diagram again within the orbit, how the eyeball and the muscles are disposed. You can see the superior oblique going under the superior rectus, the inferior oblique going under the inferior rectus. So that is an important dictum to remember. Now we'll go to the next slide. The next slide. Now the two types of muscles, voluntary muscles, is 7 in number. Involuntary muscle is the Muller's muscle. All the others are voluntary muscles. Now the next slide, the motor unit of the muscles are 1:1. Because it is not like the ballistic movements that you make with the hand and leg, but here you make fine homing movements from one object to the other, the saccades and pursuit. So the one nerve supplying one muscle fiber, one myofibril, that is the ratio. So you got medial rectus, the largest muscle with about 20,000 fibers, and you got 20,000 fibers coming from the oculomotor nerve supplying it. So that is the ratio. Oculomotor nerve, it consists of about 32,000 nerve fibers. The lateral rectus is about 6,000 muscle fibers. Next slide. And you can go fast because all these are available in the books. I'm telling something out of the book, actually, from the anatomy. The trochlear nerve is still thinner. It's got only 4,000 fibers, and the muscle has got only 4,000 fibers, and the nerve itself has got only 4,000 fibers. So these two muscles, these two nerves are liable for equal easy compression when intracranial pressure rises. So you get this lateral rectus palsy as a non-localizing sign of raised intracranial pressure. Then you got the common tendinous ring, which actually I drew in the orbit, and the muscles are arising from it. The superior oblique and the LPS arises a little outside the ring, and hence their nerve supply is also like that. The trochlea nerve is actually outside the ring. The nerve supply to the superior rectus actually, the nerve supply to superior rectus continues to supply the LPS. So there's a common supply from the superior branch of the third nerve. Next slide. Now I'll show you how they are inserted. Next slide. Now this is basically the circle of Zen in detail, more detail. I already drawn that by hand there, and you can see it. Right. They originate from the common tendinous ring. Next slide. Next slide. See, now this is the average distance of the insertions from the cornea, from the limbus. Is like this. So when you join them, you'll get a spiral of Tilla, as though it is not exactly in the same circular plane. So it's a spiral of Tilla. The superior rectus is far behind, and when we do cataract surgery and we want to fix the globe, we catch the superior rectus, bridle it first, or even in retinal detachments for scleral buckling, we bridle the superior rectus first because it's farther away. And all the other muscle insertions are nearer the limbus and easy to catch. Next slide. And what you have to understand roughly is that these insertions correspond to the ora serrata underneath. So that gives you an idea. That is a very important landmark. So just underneath these insertions will be the ora serrata. You have to bear in mind. So going through the pars plana from outside is very easy if you know these anatomical measurements. Now, superior oblique, I have shown you the arises just outside the tendinous ring, and then these fibers go towards the trochlea, the curve round, come back, and then get attached to the superior posterior temporal part of the globe, so that it acts as a rotator basically. But in various positions of the eye, it can act as a depressor as well as a abductor. Right. Next slide. Now, again, inferior oblique, I showed you in the orbit diagram where it arises from. It arises from the floor of the orbit right in front and then goes behind, goes backwards under the inferior rectus and goes to attach to the posterior inferior temporal part of the globe. Again, it's a rotator, it's an elevator, and it can also cause, it is an abductor. It can abductor. Next slide. So I'll keep the time. Next. Yeah, nerve supply. Now the nerve supply comes from the third nerve, and except for the lateral rectus, it is from the abducen nerve. So all the muscles are supplied by the third nerve, and the one lateral rectus by the abducen nerve. And there is a mnemonic there for you all to remember. Levator palpebral superior is actually a huge muscle. It arises far behind near the apex and then fans out in front. And it is the one muscle that has got some aponeurotic fibrous tissue, whereas all the other extraocular muscles, they are mostly muscles. Very little tendon, fibrous tendon is there. You get that only very close to the eyeball, and when you do squint surgery and you disinsert, you'll know only a very small portion is fibrous tendinous tissue. Next slide. No, that is about the further structure of the muscles, nerve supply. I already told you the nerve supply. These muscles help to move the eyeball in all directions. Whatever way you are doing now is all because of this peculiar insertions of the muscles on the globe. Some are inserted in front of the equator, some behind, and some have rotatory effect, some have elevation effect, like that. So it's a beautifully engineered structure, the whole eye and the muscles, and that's why you're able to move the eye in all directions. And blood supply basically comes from the ophthalmic artery, You've got the anterior ciliary arteries going along with the muscles. Next. Now, all that venous drainage has been already told. When the eyeball, the muscles have got their corresponding veins going along the arteries. This is coming to the spiral of Tilog. It is coming late in the talk, which should have been presented first. So this is the spiral I told you. These insertions, when you draw in one circle, they don't join together. There's a small disparity there. But that's the beauty of it. And we have utilized that the distance from the limbus for approaching the vitreous cavity through various sclerotomies. Thank you very much.